This is The Rounds Table. All right, welcome back, Rounds Table listeners, MedPods, Internet Work listeners. Exciting episode in store for you today. Not just because I say that every time. This one feels truly exciting, maybe. John, what article do you have up for us first?
Now, this is not going to sound exciting because it has to do with osteoporosis medications and fracture risk, but it is exciting because it's a pretty cool paper. It is the fracture prevention with infrequent Zoledronate in women 50 to 60 years of age by Boland et al., published in the New England Journal of Medicine, January 2025.
Yeah, we got to bring lots of enthusiasm because even the title of that article is boring, but I swear this will be interesting. John, what's the research question?
The question here was, does infrequent Zoledronate administration prevent vertebral fractures in early postmenopausal women?
Okay, and why did this catch your eye?
Well, bone mineral density is important, and almost universally it decreases in postmenopausal women. And at menopause, women have a 50% lifetime risk of fracture. Current strategies for fracture prevention tend to focus on those at highest risk for fracture, that is, elderly patients and those with low bone mineral density or prior fractures. But the concern is that there's still a large number of women that are being missed, with some sources indicating only 20% of fractures occur in women with low bone mineral density. So what about more of an upstream approach, like trying to prevent bone loss and trying to maintain bone mineral density to near kind of peak levels when you're a younger person? So Zoledronate, also known as zoledronic acid, is an IV bisphosphonate, and it reduces the risk of fracture among patients with osteopenia and osteoporosis. It's got a very long duration of action, and a single dose can lead to benefits that persist beyond 5 years, even after treatment discontinuation. This study sets out to investigate whether infrequent infusions help prevent vertebral fractures and maintain bone mineral density in early postmenopausal women.
Yeah, I'm like the astute listener will hear me typing away as I ask ChatGPT, what is the half-life of zoledronic acid? I feel like it's like weeks or months, but okay, total elimination half-life, extremely long. 6 days. Why did I think it was like weeks or something?
You would feel like it'd be like, months or years based on this study, but...
Oh, here it is. It's the bone half-life. The bone half-life of it lasts multiple years. What exactly a bone half-life means, I will ask ChatGPT again later. But yeah, this is interesting, not only for postmenopausal women who are at high risk, regardless of their bone mineral density, but GLP-1 analogs like semaglutide, which I will be discussing in the next article. We know that they obviously lead to weight loss, but they also lead to like decreases in bone mineral density. How come? Maybe too much information for this moment. But that's another reason why I feel like this is pretty interesting. But anyway, what was the study design for this specific trial?
So this was a 10-year prospective double-blind placebo-controlled randomized trial. This took place in New Zealand. The patient population, so it was postmenopausal women aged 50 to 60 years with a bone mineral density T-score of less than 0. But some important exclusion criteria. So if your T-score was minus 2.5 or less at any site, you were excluded. If you had any major systemic illness or metabolic bone disease, a prior spine or hip fracture, use of a bisphosphonate or hormone replacement therapy within 12 months before randomization, and any zoledronate use prior, you were excluded. So for the intervention, patients were randomized 1:1:1 to receive infusions of 5 milligrams of zoledronate at baseline and 5 milligrams 5 years later, versus 5 milligrams at baseline and normal saline at 5 years versus infusion of normal saline at baseline and at 5 years. Participants reported fractures, adverse events, and medication changes in a questionnaire every 6 months, and they also had clinical assessments including lateral spine x-rays and bone mineral density testing done at baseline, 5 years and 10 years. So for the primary outcome, it was new morphometric vertebral fracture based on spinal x-rays, and there were a few secondary outcomes, including fragility fracture, any fracture, and major osteoporotic fractures. This was an intention to treat analysis.
I swear I was paying attention and not just asking ChatGPT more about this bone half-life. So here's what it is. So zoledronic acid has an extremely strong affinity for hydroxyapatite, which is one of the key minerals in bones. And once it binds, it can remain incorporated in bone for years. So there you go, listeners. There's the bone half-life. And coming back to this trial to just show that I was truly listening. So patients were randomized 1:1:1 to either 5 milligrams of zoledronic acid at baseline and 5 milligrams 5 years later versus zoledronic acid at baseline versus normal saline 5 years later versus a couple shots of normal saline spread out at 5 years. And the primary outcome was new morphometric vertebral fracture based on spine x-rays. Do I have that right?
You got it.
Cool. And what did the included patients look like?
So 1,054 patients were randomly assigned to those 3 treatment arms. The average age was 56, the majority had European ancestry, and the estimated 10-year fracture risk at baseline was 9%.
And what did they find?
A new vertebral fracture occurred in 6.3% in those that got Zoledronate at baseline and at 5 years, 6.6% in those that got Zoledronate at baseline and placebo at 5 years, and 11.1% in those that got placebo at baseline and at 5 years. When compared to the double placebo group, those results were both statistically significant. The number needed to treat to prevent one woman from having a new vertebral fracture at 10 years was 21 in the Zoledronate at baseline and 5-year group, and 22 in the Zoledronate at baseline and placebo at 5-year group. Overall, there were few adverse events. 8 patients, which was 1.1%, had uveitis, and 1 patient, which was 0.1%, had episcleritis after baseline Zoledronate infusion, which I did not know was one of the side effects you need to be mindful of, but it is known.
Okay, yeah, new learning for me as well. So, I mean, like clearly, if you give zoledronic acid, you markedly reduce somebody's risk of vertebral fracture. I guess I'm sort of scratching my head wondering, like, how clinically important is that? I'm not an osteoporosis expert. Maybe if we have listeners who are osteoporosis experts, feel free to fact check me on this. But like, how clinically relevant is that? I'm really unsure. I'm a little bit skeptical. That feels like a limitation, but what other limitations caught your eye?
Yeah, I think that's fair. I guess the other consideration is that this was a pretty select patient population, which might impact generalizability. The exclusion criteria in detail, when you look at like kind of any major systemic illness, it included things like renal impairment if your GFR was less than 45, any chronic liver disease, but then other stuff that was a bit more vague, like any concurrent major systemic illness or major GI disease. So a pretty healthy patient population.
Okay, and what's the take-home point here?
Zoledronic acid at baseline and at 5 years was effective in preventing vertebral fractures in early postmenopausal women who did not have osteoporosis.
Yeah, like fair enough. So definitely if your goal is I want to prevent a vertebral fracture, then yes, this will help. I'm still just struck with like, what's the clinical significance of it? But how about from your perch? Does this feel practice changing?
I mean, I think it kind of does. Like, sure, I guess if we were thinking more specifically about hip fracture, that may be a little more intuitive for like just how bad things can get for people after they've sustained a hip fracture. But I can think about patients who developed bad vertebral fractures in the setting of, now this is actually osteoporosis, and like it has major impacts on their quality of life, and it can have major impacts on their functional status. But sure, maybe like the bigger outcome would have been hip fracture as the example. But I think it probably is. But the number needed to treat is remarkable. Is it too good to be true? It seems like a really well designed study though.
If it was hip fracture, 110%, I would not be skeptical at all. But I think they didn't power their study for hip fracture, probably because those are so rare relative to a vertebral fracture. But all right, well, interested to hear what the listeners think. Before we go on to the next article, a quick note from our sponsor. On Rounds Table, we usually focus on the latest in clinical research, predominantly trials and treatment updates. But today, a quick shift. We're talking scrubs, specifically figs. That's right, we have a new sponsor.
For those that don't know, they're comfortable, durable, and actually built for people in healthcare. No scratchy fabric, no boxy fit, just thoughtful design that makes your day easier.
Yeah, and tons of pockets, even for your stethoscope. And yes, I am still using a stethoscope, listeners. The antimicrobial fabric, and they come out of the wash ready to go.
A few that we like, there's the Katarina top and Cade pants for women, or the Leon top and Tansin joggers for men. They're simple, functional, and easy to move in, and like really, really comfortable.
Yeah, totally agree. When I was telling Britt about our sponsor, she's like, whoa, figs, like they have some of the best scrubs, and man, are they comfortable. And as a special promo to our listeners, you can get 20% off your first order at wearfigs.com with the code all caps FIGSCA. Again, that's wearfigs.com with a code FIGSCA to save 20% on your next purchase. All right, and article number 2, semaglutide in adults with type 1 diabetes. That's right, type 1 diabetes and obesity, published in NEJM Evidence.
Hold on a minute. Type 1 diabetes. Oh, okay. What's the research question here?
For adults with type 1 diabetes and obesity, what is the efficacy and safety of semaglutide?
Okay. This is important, I think, for lots of reasons, but what do you think?
So, the mainstay of treatment for adults with type 1 diabetes is insulin, like full stop. And there have been very few, you know, emergent or innovative options for treatment for people with type 1 diabetes since insulin was discovered over 100 years ago now. Uh, I am, of course, oversimplifying things. We know that automated insulin delivery, so like think insulin pump, has really improved outcomes for adults with type 1 diabetes, but there really haven't been, new treatments. Sure, SGLT2s have been tried. In general, SGLT2s in adults with type 1 diabetes often leads to a markedly increased risk of diabetic ketoacidosis, and it hasn't yet made it into the guidelines that SGLT2s should be used in this patient population, mainly because of that really important risk. So, how about semaglutide in the setting of a person who has both type 1 diabetes and obesity? A reminder to our listeners that all the randomized trials supporting the efficacy and safety of semaglutide to date have been in two distinct populations, actually, probably more than two distinct populations. But the origin has been, in adults with type 2 diabetes. It is so crystal clear that semaglutide improves outcomes and improves cardiovascular outcomes. Separately, in adults with obesity who do not have diabetes and are increased cardiovascular risk, we know it reduces their risk of a subsequent MI, stroke, or death from cardiovascular causes. But there really haven't been trials in the type 1 patient population.
Yeah, that's really important to remember because, like, of course, we've all seen the patient who has type 1 diabetes who comes in with all of the cardiovascular complications. And so, of course, the purpose of this study is not those outcomes. But if there was a signal that this could be an important medication, that'd be really important to find out. So, how did they do this study?
This was a 26-week phase 2 double-blind, non-industry funded placebo-controlled trial running from 2022 to 2025. In general, the included patients were adults aged 18 to 65 with a clinical diagnosis of type 1 diabetes. A few key inclusion, they had to be on an insulin pump, but to be honest, like that's standard of care, so that makes sense to me. Their A1C had to be between 7 to 10%. They had to have a BMI of at least 30. A few key exclusion criteria: if they had been on insulin for less than 12 months, if they were pregnant, if they previously used a GLP-1 analog, if they had a GFR less than 45, which makes no sense to me, or if they've had prior severe hypoglycemic episodes or a history of pancreatitis. The intervention, so once weekly semaglutide and up titrated to 1 milligram per week, which is like a moderate dose of semaglutide. As listeners probably know, we start at 0.25 and then you can go up. For patients with obesity, you can go, beyond 2 milligrams. The comparator is placebo. The outcome was this time in range of more than 70% and reduction in body weight by 5% by 26 weeks. Some people might be familiar with time in range, some might not be familiar with that, but this is really like a superior outcome compared to just change in hemoglobin A1C. The time in range is a much better indicator of somebody's glycemic control compared to, say, hemoglobin A1C.
Perfect. So, who are the patients? What do they look like?
So overall, average age of 40 years, 60% were female, 90% were white. Average BMI was 35. Average A1C was approximately 8%. And on average, these adults had type 1 diabetes for approximately 23 years.
Okay, so what did they find? Do we have yet another indication for semaglutide?
So here's a few of the key things they found. The hemoglobin A1C fell by 0.7 percentage points with semaglutide compared to 0.4% reduction with placebo. They also observed nearly a 10 kilogram weight loss with semaglutide compared to essentially no change with placebo. The actual proportion that achieved that primary outcome, so the time in range, as well as a reduction in body weight of at least 5% by 26 weeks, that occurred in 36% of patients who got semaglutide and 0% of patients who got placebo. There was 2 severe hypoglycemic events in each group. There were no DKA events, and the other adverse events with semaglutide were in keeping with what we know, diarrhea, constipation, nausea, vomiting, etc.
Okay, what were some of the limitations here?
This is a small trial, it's a small group of individuals. I actually don't even know if I told the listener how many overall patients were included in the study, but I will report that, I swear. So small study, small duration of follow-up, right? Like 26 weeks in total. That's a really short period of time. And yes, the total number of patients included were 72. So, that was a phase 2 trial. You can also ask yourself, is it truly a blinded study? Like, don't people know if they got the good stuff because they see a massive reduction in their weight compared to if they got placebo? Those are the key important limitations, I'd say.
Yeah, okay. What's the take home here?
For adults with obesity and type 1 diabetes, semaglutide improves glycemic control and weight, albeit in this phase 2 setting and a relatively small clinical trial.
And I guess acknowledging phase 2 trial, so maybe hard to comment specifically on practice changing, but what do you think? Do you think there's going to be a signal here when the phase 3 data comes through?
Yeah, this definitely suggests it will. I guess we'll wait to see, what comes down the pipeline. And I'm very curious to hear what our listeners think, especially those with, more experience than us caring for patients with type 1 diabetes. But in all honesty, if I was looking after a patient with type 1 diabetes, let's say up in the Sioux, and their BMI was 35, and they said, "Doc, I've tried a ton of things to lose weight. I haven't been able to. I keep hearing about this wonder drug Ozempic. Do you think I should give it a try?" I would probably say yes, and let me tell you about the best available data we have for whether or not it will help you.
Yeah, that's fair. At least we have some information that we can comment on.
Yep. All right, John. Well, that is it for today's episode. Good stuff. What caught your eye?
This good stuff is from the tennis world. Canadian tennis phenom Victoria Mboko. She wins the 2025 Canadian Open, but it was a pretty remarkable feat. So she started the tournament ranked around 300 in the world, and she just kept on winning. She won the quarterfinals, she won the semi, and then of course she wins the finals in dramatic fashion. And now she's climbed to number 24 in the world, so it's pretty impressive. I think is she 18 years old, 19 years old? So quite remarkable.
Very impressive stuff. On my end, highlighting the I'm Pharmacy podcast. We will soon be hosting it at medicinepods.com, which is super exciting. The I'm Pharmacy podcast is led by good colleague and friend, Dr. Mina Tadros. He's a pharmacist and researcher at the Leslie Dan Faculty of Pharmacy and assistant professor. And it's just a really great podcast that captures content that I haven't heard elsewhere. It's mainly revolving around the world of pharmacy, but he talks to experts in drug discovery. He covers things like drug shortages. He covers policy. He covers AI stuff. So just a great podcast, and super excited for it to soon be hosted at Medicine Pods.
Yeah, that content is really interesting. I'm looking forward to checking out their episodes.
All right, John, that's it for today. Stay well, and we'll chat again soon.
Talk to you later, Mike. The Rounds Table is hosted online at medicinepods.com, your one-stop source for comprehensive internal medicine education and evidence-based medicine resources. We can also be found on all of your favorite streaming services. You can also follow us on Instagram, LinkedIn, and X. And special thanks to our audio editor, Tamara Van Bakel.